glomerulonephritis, or PSGN. PSGN is the most common cause of nephritic syndrome in children. It is a potential complication following infection with Group A streptococci. Group A streptococci, also known as Streptococcus pyogenes, are gram-positive beta-hemolytic bacteria that grow in chains. PSGN occurs following skin and throat infections with certain strains of Group A streptococci that produce nephritogenic antigens. During the immune response to the initial infection, B cells generate IgG antibodies against these nephritogenic antigens. Although the streptococcal infection is localized to the skin or pharynx, some of the nephritogenic antigens are able to enter the circulation. There, they bind circulating antibodies to form immune complexes that are deposited along the glomerular basement membrane. The deposited immune complexes then trigger a type 3 hypersensitivity reaction involving cleavage of the C3 complement component with subsequent neutrophil recruitment. The resulting inflammatory response can be seen on light microscopy, which shows enlarged hypercellular glomeruli due to leukocyte infiltration and subsequent proliferation of glomerular cells. More advanced techniques, such as immunofluorescence and electron microscopy, can identify the immune complex deposits themselves. Immunofluorescence will show granular, lumpy, bumpy deposits of IgG and C3 along the glomerular capillary walls and mesangium. The nephritogenic immune complexes tend to activate complement via the alternative pathway, so deposits are less likely to contain classical complement components such as C1q or C4. Electron microscopy can further identify subendothelial and subepithelial electron-dense immune deposits on the glomerular basement membrane. The large dome-shaped deposits on the epithelial side of the membrane are known as humps and are a characteristic feature of PSGN. The subepithelial immune deposits predominantly damage glomerular podocytes, promoting proteinuria, while the subendothelial immune deposits are responsible for the more generalized glomerular inflammation that causes hematuria and acute kidney injury. PSGN typically presents 7 to 10 days after pharyngeal infections or 2 to 4 weeks after skin infections such as impetigo or cellulitis. The lag in symptoms corresponds to the delay in antibody formation and immune complex deposition. Because of this, some patients may not report a history of antecedent infection. Presentation can vary from only microscopic hematuria to overt nephritic syndrome. Most children are asymptomatic, but many others develop one or more characteristic nephritic symptoms. Gross hematuria results from glomerular capillary disruption and frequently manifests as tea or cola-colored urine. Hypertension and edema can develop due to impaired glomerular filtration and the resulting water and sodium retention. Patients also have laboratory evidence of glomerulonephritis. Urinalysis shows hematuria, often with dysmorphic red cells and red cell casts that are indicative of a glomerular bleeding source. Other common findings include pyuria secondary to glomerular inflammation and nephritic range proteinuria, which can cause decreased intravascular oncotic pressure and contribute to edema formation. Nephrotic range proteinuria is uncommon since glomerular inflammation reduces filtration capacity, limiting the total amount of protein that can be excreted. The impaired glomerular filtration also commonly causes elevated serum creatinine and blood urea nitrogen levels, which are indicators of acute kidney injury. Another characteristic laboratory finding is decreased C3 levels secondary to consumption in the glomeruli. C4 levels are typically normal as complement activation via the classical pathway is not prominent in the condition. Patients also have elevated titers of anti-streptococcal antibodies, including anti-streptolysin and anti-hyaluronidase. The diagnosis of PSGN is made in patients with signs and symptoms of acute nephritis and either a history or laboratory evidence of recent Group A Streptococci infection. Management of PSGN focuses on supportive care and treatment of complications such as hypertension. The prognosis of PSGN is generally favorable, particularly in children. The majority of pediatric patients have complete clinical recovery within weeks. However, as many as 40% of adults develop chronic kidney disease, with 10% progressing to end-stage renal disease. To sum up, here are the key points to remember. PSGN is the most common cause of nephritic syndrome in children and is caused by infection with nephritogenic strains of Group A Streptococci. Pathogenesis involves production of IgG antibodies against nephritogenic antigens, which then combine in the circulation to form immune complexes that deposit on the glomerular basement membrane. Symptoms usually develop 7 to 10 days after pharyngeal infection or 2 to 4 weeks after skin infections. Many patients are asymptomatic with only microscopic hematuria, but others can develop one or more findings of overt nephritic syndrome, including gross hematuria, edema, proteinuria, hypertension, and increased serum creatinine. Low serum C3 and normal serum C4 levels are also characteristic. The diagnosis is made in patients with findings of acute nephritis who have history or laboratory evidence of recent streptococcal infection. Treatment is supportive. Most children recover completely, but adult patients have a relatively poor prognosis and higher risk of chronic hypertension and renal insufficiency.